Good evening, dear students. Welcome to this session, Dream Duo Marathon. And today we are taking care of anatomy and surgery. Myself, Dr. Rajesh Kaushal, and your favorite, lovely surgeon, Dr. Pritesh. So today what we will do is some of the basic anatomy I'll be looking into, and then I'll hand over to Dr. Pritesh. He can take care of the surgery aspect of few questions. I'll be taking care of 5 questions on the topics which are latest. And what we'll do is some of the latest topics which are important for the purpose of the upcoming exams. Integrated session means where we are basically looking at interdisciplinary type of questions, where you need the requirement of anatomy basics plus moving on to surgery. It could be a surgery question itself, or could be anatomy question moving on to surgery aspect. And this session, as it finishes, total 10 questions. By the end of the session, you can ask us questions in the chat YouTube session, and we'll be looking at the details and trying to answer your queries. So I would like to invite Dr. Pritesh now. Sir, please introduce yourself to the students and welcome them.
Hello, everyone. Welcome to this Dream Duo Marathon. So we are having this session of anatomy and surgery together, and Dr. Rajesh Kaushal will be starting the session first. And you can ask all your doubts in the chat box. We will be taking care of those doubts at the end. So, sir, please continue.
All right. Thank you, Dr. Pritesh. We are beginning with the first question here. You might be aware of this question. It came a while back and is asking us, left recurrent laryngeal nerve, which is a branch of the vagus belonging to 6th pharyngeal arch, is having a comparatively longer course when it comes to the left side. So why the left recurrent laryngeal nerve is longer as compared with the right is the question, and asking which of the pharyngeal arch artery is actually persisting so as to lead to this kind of difference. We'll look at the answer, but let us first look at some of the diagrams to get some details. Now, as we know, we have developed evolution-wise from the fishes, and like fishes, we don't have the gills, but we developed what is called as branchial apparatus or pharyngeal apparatus. Fishes will also have some arteries in the neck region, but we have got some modifications. So what are the modifications? Actually, there are total 6 pharyngeal arch arteries, out of which 3 will disappear and 3 will persist. Arch number 1, 2, and 5, they are almost disappearing, but the arches which remain, they are basically the arch number 3, 4, and 6. So if we are talking about the arch number 3, what is it giving? Arch number 3, as is evident, on both sides, it will be contributing towards the internal carotid artery, and even the external carotid artery will take a bud from there. Coming to the arch number 4, if you look at the right side, it will be contributing to right subclavian artery, whereas on the left, it is contributing to part of arch of aorta. So 4th arch has some difference when it comes to embryological development. 6th arch, on both sides will be forming the pulmonary arteries, the right branch, left branch of pulmonary artery. So this is the 6th one. And let me show you the diagram where we actually have the adult situation. Now what happens is 4th arch has a nerve also, a branch of vagus, the superior laryngeal nerve, whereas the 6th arch is a branch of vagus, recurrent laryngeal nerve. Let us look at recurrent laryngeal nerve detail because the question is upon that. So as we look at the adult situation now, you will notice Looking at the front view of the head neck region, this is the beginning, that is the final stage. You will notice that this is the third artery, which has contributed to the internal carotid artery, external carotid artery. And then when it comes to fourth arch, as we mentioned, part of the right subclavian artery, where on the left side it will be part of arch of aorta. Sixth arch, contributing to pulmonary artery on the right as well as left. Now, there is one difference. On the right side, the sixth arch artery just forms the pulmonary artery. There is a communication. It is disappearing. And because that communication disappears and is persisting on the left side, which will be later called as the ductus arteriosus. Due to that presence of ductus arteriosus only on the left side, not on the right side, there is a difference of change of the course of recurrent laryngeal nerve. You will notice on the left side, if we are, let us zoom this little bit, you will notice that when we are looking at the left side, say, let us take this color. As you find, this is the vagus nerve, and vagus nerve has given a branch which is called as recurrent laryngeal nerve. And this recurrent laryngeal nerve is basically hooking under ductus arteriosus in fetal stage, but in the adult, it will be called ligamentum arteriosum, attaching to arch of the aorta. And the left recurrent nerve, what it does is, it'll enter the superior thoracic aperture, go into the thorax, hook under the arch of aorta, and come back towards the larynx because it has to supply the larynx muscles. This is on the left side. On the right side, you see, since we do not have ductus arteriosus, it was disappearing. The fifth arch arteries already, they don't exist. So the nerve, which is on the right side, the recurrent laryngeal nerve, is actually finding nothing to hook around the sixth arch. Fifth arch, it is already not there. So it hooks under the fourth arch. That means on the right side, the recurrent laryngeal nerve is hooking under right subclavian artery at a higher level. It doesn't even enter the thorax. That is why when there is superior thoracic aperture, thoracic outlet syndrome, the nerve which can get involved is left recurrent laryngeal nerve because it is entering and exiting superior thoracic aperture, and not the right, because right remains in the neck region. Let me show you the next diagram, and it will be evident now. See, this is the final situation. We wanted to know about the left-sided recurrent laryngeal nerve, and it is obviously longer because it is coming from the thorax region, hooking under the arch of aorta, hooking under ligamentum arteriosum. So which artery was persisting? So as to make the left nerve longer, sixth arch artery derivative, ductus arteriosus or ligamentum arteriosum. That should be your answer. Whereas on the right side, you see, it is hooking under the fourth arch artery, which is the right-sided subclavian artery. So the right nerve is going in the neck region only, shorter, whereas the left nerve is quite long, goes into thorax, come back from the thorax into neck. They have to go to the neck because they have to supply laryngeal muscles. Let us go back to the question now. As we go back to our question, it was actually asking, the left recurrent laryngeal nerve is comparatively longer. And why is that? We have found because of the persisting sixth arch artery on the left. On the right, it was disappearing. So right became shorter and left is longer. That is why in this question, as we understand, the answer should be choice number D. Now, I will also move into one detail, which Dr. Pritesh is going to take care of. But here, one thing which I want you to understand is, when we are talking about these arteries and these nerves, the nerve of the fourth arch, which is branch of vagus, superior laryngeal nerve, and nerve of sixth arch, recurrent laryngeal nerve, their relation with the arteries are, like you can see here, This is the region where you will have the thyroid gland. Now, if you want to remove the thyroid gland, means you want to do thyroidectomy, for that you have to ligate some of the arteries. Like you see, one artery we can discuss here is the superior thyroid artery, branch of external carotid artery. And this is also shown on the other side. Now, you have to ligate this superior thyroid artery to remove the thyroid gland. Similarly, you have to remove inferior thyroid artery as well, which itself is a branch of thyrocervical trunk, is a branch of the first part of subclavian artery. And the subclavian artery there, you had this nerve we are talking about, this nerve taking a loop, that is the recurrent laryngeal nerve. Now, recurrent laryngeal nerve comes in close contact with the inferior thyroid artery while it was going towards the larynx to supply larynx muscle. And the superior thyroid artery comes in close relation with the branch of vagus, which is the superior laryngeal nerve, actually giving the external laryngeal nerve and to supply a muscle of the larynx, cricothyroid muscle. So the point is, since the external laryngeal nerve is going close to the superior thyroid artery and the recurrent laryngeal nerve is going close to the inferior thyroid artery, where should you ligate these arteries and not damage these respective nerves? And there, you have to ligate them as close as possible to thyroid gland. Now, why should you ligate the superior thyroid artery, inferior thyroid artery, as close as possible to the thyroid gland? I hand over this discussion to Dr. Pritesh now. Sir, please.
Yes. Hello, everyone. So let's see the question related to thyroidectomy, because thyroidectomy is very, very important topic. It is frequently asked in NEET PG, AIMS. You have seen INI-CET questions. In that also, almost every year, you will get one question. So see the question related to thyroidectomy. So the question is, which of the following is incorrect related to thyroidectomy? Superior thyroid artery is ligated close to thyroid. Inferior thyroid artery is ligated close to thyroid. Most commonly injured nerve is recurrent laryngeal nerve. And middle thyroid vein is ligated first, followed by superior thyroid, inferior thyroid vessels. So I want students, you first mark your answer so that I can proceed for the discussion. Which one is incorrect? A, B, C, D. Which one is incorrect? Yes, Pavan Kumar, Sushruta, C, correct. Hem Singh, C. Debulina, C. Lokesh, Bajaj, C. Alia Khan, C. So I hope everybody is knowing the answer. So let's start the discussion. Okay. So the first option is that superior thyroid artery is ligated close to thyroid. So Dr. Kaushal has explained everything beautifully that's why you people are marking correct answers. So see, superior thyroid artery is ligated close to thyroid, not only artery, even vein also. Why? To prevent the injury of external branch of superior laryngeal nerve, and that is also known as external laryngeal nerve. Why inferior thyroid artery or inferior thyroid vessels are ligated close to thyroid? Because you know there is a gland, parathyroid gland, and this parathyroid gland is supplied by parathyroid artery. And you know that this parathyroid artery is an end artery. So have a look. So inferior thyroid artery, you know, this inferior thyroid artery why it is ligated close to thyroid? Because there is a branch supplying parathyroid gland. And which artery? It is parathyroid artery. So parathyroid artery, it's an end artery. Okay. And whenever we are going to ligate inferior thyroid artery away from thyroid, what happens? It's something like this. So if you're going to ligate it away from thyroid, it will lead to vascular infarction. And if it will lead to vascular infarction, you know that generally after thyroidectomy on 2nd to 5th day, patient is going to develop parathyroid insufficiency. So I'm repeating again why we are going to ligate superior thyroid artery close to thyroid to prevent the injury of external branch of superior laryngeal nerve, that is also known as external laryngeal nerve. Why we ligate inferior thyroid artery close to thyroid to prevent vascular infarction of parathyroid gland. Another misconception which students have in their mind, that overall in thyroidectomy, what is the most commonly injured nerve? See, it is not recurrent laryngeal nerve. It is external branch of superior laryngeal nerve or external laryngeal nerve. Another important point, whenever we are performing thyroidectomy, there is a short vascular structure here, and that is middle thyroid vein. It's very short. So what is the problem? Whenever you are performing dissection or retraction of thyroid, this vein gets avulsed. And if the vein is avulsed, what's the problem? There is bleeding as well as increased risk of air embolism. So in the vessels, superior thyroid vessels, inferior thyroid vessels, and middle thyroid vein, you tell me which structure is ligated first. Tell me, Alia, Hemsing, tell me which structure. It is the middle thyroid vein, which is ligated first. Okay, so see the question again. If you see the question again, superior thyroid artery is ligated close to thyroid. This is correct. Inferior thyroid artery is ligated close to thyroid. Correct. Most commonly injured nerve is recurrent laryngeal nerve. No, it is external branch of superior laryngeal nerve. And fourth option, middle thyroid vein is ligated first, followed by superior and inferior thyroid vessels. Why? Because if you are not going to ligate it, what happens? There is avulsion of this vein, and this leads to air embolism. This leads to air embolism. Clear? So correct answer for this question is C, because this option is incorrect. Okay. So I request Dr. Kaushal to continue. Sir, please continue.
Thanks a lot, Dr. Pritesh. That is a wonderful explanation. That is what we call it as an interdisciplinary approach. And I'll just quickly revise what sir has mentioned, that if we are going to ligate the superior thyroid arteries, we should ligate them as close as possible to the gland, because we don't want to include superior laryngeal nerve in our ligature. Similarly, though, earlier there used to be older concept, but the new concept for the inferior thyroid artery is inferior thyroid artery also should be ligated as close as possible to the gland, because maybe you have a chance of injury to recurrent laryngeal nerve, but still you have to follow this approach. If you ligate it earlier, just to prevent injury to the recurrent laryngeal nerve, you might be putting the parathyroid gland into the chances of ischemia. So the arteries must be ligated as close as possible to the gland, maybe superior or inferior, to prevent the parathyroid gland ischemia for the case of recurrent laryngeal. Anyway, let us move on to the next question. And what I want you to actually appreciate is these topics, though they are repeatedly asked very frequently, but then we tend to make mistakes in these kind of questions. In anatomy, there are various terminologies which might be confusing, and we have to know 5 or 6 names for a single entity. Here, as you notice, we are talking about what is not associated with the Vitello-intestinal duct. Now, Vitello means the yolk sac. Intestine is the gut tube. There is one more name which comes for the same structure. We call it as omphallomesenteric duct. So you must be careful about using these terminologies. Vitello-intestinal duct is also called omphallomesenteric duct. Now, normally, this duct is embryological. It must disappear, but it may be persisting. And if it is persisting, there can be Meckel's anomalies. Meckel anomalies will always have the lining of gut tube. It is the serosa, it is the muscular layer, the submucosa, the epithelium. Now, the examiner may be asking, Vitello-intestinal duct, that is Meckel's duct, cyst, Meckel cyst, Meckel fistula, Meckel sinus, or he can use the term omphallomesenteric cyst. Now, there is omphallomesenteric cyst and there is a mesenteric cyst. There's a difference. Mesenteric cyst is a cyst in the mesentery and it'll have no layers of gut tube, which we mentioned, the mucosa, submucosa, muscular layer, serosa is present in vitello-intestinal duct or omphallomesenteric duct, but not in mesenteric cyst. So immediately we should be able to answer the choice number D as the exception. Then what is this ileal diverticulum? It is the Meckel's diverticulum only because it attaches terminal ileum. You can call it as ileal diverticulum. You can call it as enteric diverticulum also, various terminologies. Now, what about umbilical fistula? These ducts, the vitello-intestinal duct is connected to the umbilicus. At the umbilicus, the connection should be disrupted, but if it is persisting, problems can execute themselves at the level of umbilicus. Could be umbilical fistula, could be umbilical sinus. What is the difference between a fistula and sinus? That we'll have to find out. And can it be enterocystoma? What is this enterocystoma? Entero means it is the intestine and a cyst in the intestine. You mean to say Meckel cyst? Yes, that is what. See, the examiner is just playing with the words. You must know enterocystoma is the other name of Meckel cyst. This is Meckel fistula. That is Meckel diverticulum. And let me just take you to some of the embryology here. You'll notice that when we are talking about the development, you are looking at a developing baby from the side view. The umbilical cord is having this duct, which is called as vitello-intestinal duct. As you start from the beginning, let me tell, say, this is the gut tube here, having a foregut component, then there is a midgut component, and then there is a hindgut component. Let me zoom this a little bit. During development, we notice that it is the abdominal cavity is small, gut is growing faster. So part of the gut, that is midgut, enters into the umbilical cord, physiological umbilical hernia, week number 6. And it is having one communication. You see this communication, let me put it with some other color. This is the vitello-intestinal duct, which is connecting the midgut with the yolk sac here. So in the beginning, the yolk sac has a communication with the midgut, and that duct, vitello-intestinal duct, is also a content of the umbilical cord normally. Now, after some time, the yolk sac will disappear. Vitello-intestinal duct will be obliterated. The midgut will go back into the abdominal cavity. As the abdominal cavity becomes larger, regression of physiological umbilical hernia, that is normal. If there's a non-regression of physiological umbilical hernia, we will call it as omphalocele. That is a different entity. But here we are talking about what will happen if there's a persisting vitello-intestinal duct. Then we can have what is called as Meckel's diverticulum, where it will be attaching to the midgut. Which part of midgut? The terminal ileum. And it is a true diverticulum. Why would you say it is a true diverticulum? Because it has all the 4 layers of gut tube. Let me show the details now. As you move on, you see it is also having a particular location. See, again, looking from the side view, and this is the midgut. From the midgut towards the anterior abdominal wall, you find this is the vitello-intestinal duct connecting to the yolk sac and going outside the umbilicus, and it must be obliterated. It is at the anti-mesentery border. Why would you say that? Because it is attaching to the umbilicus, anterior abdominal wall, whereas mesentery attaches to posterior abdominal wall. So vitello-intestinal duct is lying anterior, it is anti-mesenteric border. These are all MCQs. Now, as we proceed further, this must have disappeared. And if it is not disappearing, what will happen? In some babies, it may persist. And if it is persisting, you can see it is called as the Meckel's diverticulum, and it will be attaching to anti-mesentery border towards the umbilical side. There could be a fibrous adhesion with the umbilicus on anterior abdominal wall, and this diverticulum may actually open to the umbilical side, or it may present with altogether different variety. Let me show the varieties they can present with. Say, in a baby, you found, because these are all latest questions, in a baby, what you found was just one Meckel's sinus. What is the difference between a sinus and a fistula? See, sinus is one opening. Fistula is double opening. And what is a cyst? Cyst has no opening. There can be a Meckel cyst, there can be a Meckel fistula, or there can be a Meckel sinus. If the proximal part was obliterated, only distal part was patent, then you will have an opening in the umbilicus, which is called the Meckel sinus. Some mucoid secretion might be there, but no content of the gut tube. If you find the content of the gut tube coming out, then it is coming from terminal ileum, and it is double opening, one at the umbilicus and one at the terminal ileum. It is a Meckel fistula. Or it may happen that proximal portion of the Vitello-intestinal duct is obliterated, distal portion is obliterated, only the center is there. So Meckel cyst. And with that orientation, we already have actually answered our question. So I would like Dr. Pritesh to take over now. And the answer to this question was choice number D. And I would request Dr. Pritesh to move on with some more details regarding the same clinically.
Okay, thank you, sir, for a beautiful explanation. And Meckel's diverticulum is very, very important topic. It is asked in final year exam also. It is asked in pre-PG also. AIMS, INI-CET, NEET PG, everywhere it is asked. And let me discuss one latest question. See the question, tell me the answer, then I will discuss it. The question is, a 3 days old baby was brought to the hospital with history of passage of greenish yellow fecal discharge from the umbilicus. Now, can you see greenish yellow fecal discharge? It means whatever the discharge is coming, this discharge is coming from the gut. Greenish yellow fecal discharge. What shall be the embryological cause for this condition? Now, you people first tell me the answer, then I'm going to discuss the question. Tell me the answer. Muhammad, B. Very good. Pawan, B. DG, B. C. Debolina, B. Sushruta, B. Lavanya, Shiva, B. Pooja, C. Manoj, B. So majority of you are correct. The correct answer is B. And sir explained everything beautifully. See this diagram. Sir was using the term Meckel's. It is also known as Vitello-intestinal duct. So Vitelline fistula, right? Now see, sir discussed that this is the Vitello-intestinal duct, and after birth, it is obliterated. Okay, this is obliterated. This is umbilical end, and this is the intestinal end. Now see, whenever this Vitello-intestinal duct, it is patent. Here you can see it is patent. And if it is patent, obviously it is fistula. You know what is fistula? Fistula is communication between two epithelium lined surfaces. Sir told that fistula are having two openings. Sinus is having one opening. Cyst is not having any opening. So if it is patent, it is known as Vitelline fistula. Simple. Now here, see, if there is persistent Vitello-intestinal duct on which side? On intestinal side, then it is known as Meckel's diverticulum. And whenever there is patent Vitello-intestinal duct on which side? Umbilical side, and there is single opening, and sir explained that sometimes there is mucoid discharge, but discharge from gut tube is not there. Discharge from gut tube is not there. And in the question, what kind of discharge was there? Greenish yellow fecal discharge. Okay. Fourth situation, whenever some mucus is collected in the remnant, yes, without any kind of opening, that is known as cyst. So it is Vitelline cyst, right? And sometimes this Vitello-intestinal duct is replaced by a band or a cord that is known as Vitelline band. Simple, this is a simple concept. See the diagrammatic representation. Now you can tell me, what is the diagnosis? Meckel's diverticulum. Here you can see communication between bowel and umbilicus. So this is Vitelline fistula. Here you can see single opening towards umbilical end. This is sinus. No opening. This is cyst. And sometimes there is cord. This is known as Vitelline band. And there is one anomaly. Meckel's diverticulum, sometimes what happens, the umbilical end is having a cord or a band, and intestinal end is persistent. So this is the Meckel's diverticulum. It's the dangerous anomaly. Why? Because since it is fixed to umbilicus, there is twisting. So if there is twisting, it can lead to what? Mid-gut volvulus. Simple. So these are the important points related to Vitello-intestinal duct anomaly. So see the question again. If you see the question again, in the question, 3 days old baby brought to the hospital with passage of greenish yellow fecal discharge from umbilicus. It is because of Vitelline or Meckel's fistula. So what is patent? Patent Vitello-intestinal duct. So most of you mark the correct answer. Correct answer for this question is B. This is Vitelline fistula, or there is patent Vitello-intestinal duct. So sir, please continue.
Thanks a lot, Dr. Pritesh. And somehow you have taken me back into my surgery wards. There used to be very famous teacher for us, and he will explain very nicely. Somehow it was a nostalgic feeling, and wonderfully you have explained it. Thanks a lot. The students are really lucky to have you there. Okay, so we need to move on to this next discussion here. See, whichever question we have taken, they are all very hot topics, latest topics, and interdisciplinary in approach. And as usual, like I'll take care of the anatomy portion. It is asking us a false statement about the anatomy of inguinal hernia. Though a hernia goes in the territory of surgery, but it is kind of a gray area. There's a gray area, anatomy and surgery. Between them, what is this gray area? The surgeon will not teach that anatomy part, which he thinks anatomy faculty would have taken care of. And anatomy faculty will not teach the gray area because he will think that surgeon will take care of that anatomy. So that gray area is where the questions come. Anyhow, what is the false statement we want to know? Is the superficial inguinal ring an opening in the external oblique aponeurosis? We know, yes, it is correct. Where is the deep inguinal ring? Deep inguinal ring is a defect in the transversalis fascia. In the anterior abdominal wall, we have some muscles in the anterolateral aspect. External oblique muscle you remove, then you get the internal oblique. If you remove that, transversus abdominis muscle. If you remove all the three, transversalis fascia. And if you remove that, then peritoneum and the abdominal viscera. So if the social ring is an opening in external oblique aponeurosis, deep ring is transversalis fascia. What happens to the muscles which were in between? They form the wall of the inguinal canal. We'll see in some diagrams, but you see in direct inguinal hernia, which is mostly embryological, coming from the deep inguinal ring area, is it lying medial or is it lying lateral to inferior epigastric artery? That is where we have got a hint, and I'll come back to that. But let us first look at the anatomy of inguinal canal. Then we can come back here. Is the posterior wall of the inguinal canal or the hernia, which is the viscous or omentum coming out, is it the transversalis fascia posterior? Is the conjoint tendon posterior? We have to find out what is this conjoint tendon. And what about this indirect hernia? Is it anteromedial to spermatic cord? This is more of a surgical aspect, but some basic anatomy is required. So let me take you to the details, and starting from the very deeper aspect, we are actually looking at, say, let me just begin from here. First, I need to tell you why the inguinal canal is actually formed. That is also important to know. We know that the testis will be actually developing in the abdomen region. The gonads develop in the abdomen. Later, they descend down towards the pelvis, and in male, the testis is actually moving out into scrotum because the testicles, they have to form the sperm, and sperm require a little lower temperature, so they go outside. Now, if this testis was moving from abdomen into the pelvis, it is passing out through the anterior abdominal wall musculature, those three muscles, and passing inguinal canal will enter the scrotum for a male. In that process, when the testis is coming out of anterior abdominal wall into the scrotum, it will develop some layers of the muscles which we just mentioned, external oblique, internal oblique, transversus abdominis. But there should be some opening also. The deep inguinal ring and superficial inguinal ring. So let us talk about them. I will be focusing mostly on the right-sided inguinal canal. This deep inguinal ring, which is just above the femoral artery. You can take the femoral artery pulse here, and just above where you take the femoral artery pulse or mid-inguinal point, just above that is deep inguinal ring in an adult. And it is an opening in deepermost transversalis fascia, not the muscle, transversalis fascia. And what is this inguinal canal length in an adult? About 4 centimeters. It becomes oblique due to development of the abdominal wall. Inguinal canal is oblique. In the beginning, it was straight, but then it becomes elongated. And what is this opening in the social? What is the social inguinal ring? Opening in the last muscle, external oblique aponeurosis. Let me show that in a sequence as well to have a better idea. See, the very first thing which you have to tell is, as I am telling, we are looking at the right half of the abdominal wall. So as the testis was coming, we are mentioning this testis had to pass from abdominal cavity outside, and there is an opening. We are calling that opening as deep inguinal ring. It is in the fascia transversalis. And look at one detail here. We were talking about this artery, femoral artery. Femoral artery is below inguinal ligament. If femoral artery is below inguinal ligament, what is before that? It is a continuation of external iliac artery, common iliac artery, abdominal aorta. Abdominal aorta will give us the common iliac, will give external iliac, will give femoral artery. There you get a branch of external iliac artery, which is surgically very important. So that branch of external iliac artery, which is going to enter rectus sheath also, is called as inferior epigastric artery, and it is a landmark. The deep inguinal ring lies lateral to that. That is why when you talk about indirect inguinal hernia, congenital mostly, the viscous which is coming from abdomen into the inguinal canal into the scrotum, the viscous will be lying lateral because it is passing deep inguinal ring. And in adults, in older people, abdominal wall musculature is lax. Hernia can come out. That is direct inguinal hernia. And how do you differentiate direct from indirect? Indirect inguinal hernia is viscous or omentum coming from deep inguinal ring, lateral to inferior epigastric artery. Whereas in an adult, as we all know, it will be actually coming here. Hasselbalch's triangle, medial to this artery called inferior epigastric artery. That will give you the answer to the question. Anyhow, now when the testis came here, it was followed by spermatic cord. Spermatic cord is actually carrying the sperms back because testicles will form the sperm. You have to carry it back towards the urethra for ejaculation. So spermatic cord came, testis will be hanging here, and it has to carry the sperm back. And if testis is here, it has to carry some blood vessels for testis. Testicular vessels will be there inside the spermatic cord. Now, this spermatic cord is passing through inguinal canal. And what are the boundaries of that? We want to see. The last thing which we had, transversalis fascia. What is the next muscle? Transversus abdominis muscle, and then internal oblique, then external oblique. So it has to pass through all those muscles. Let me take you to the next muscle. So which will be the next muscle? If this is transverse salis fascia, we'll have the transverse salis muscle or transverse abdominis muscle. And somehow you have to remember one thing clearly here. Transverse abdominis muscle is lying in such a way that it is not forming the anterior relation of spermatic cord or inguinal canal. Now, if transversus abdominis muscle is not forming anterior relation of the spermatic cord or inguinal canal, then what is it forming? It is just forming the roof of the inguinal canal or spermatic cord or the hernia as per se, and posterior wall. So posteriorly, what do you have? Posteriorly, obviously, you have transverse salis fascia and transversus abdominis muscle. But along with transverse abdominis, there is one more muscle, and two muscles contribute to conjoint tendon. Conjoint tendon is the tendon of transverse abdominis and one more muscle, which was more anterior. And which is more anterior? Internal oblique. So conjoint tendon is the joint tendon of two muscles, transversus abdominis and the internal oblique. Now, internal oblique, what relation it will have? Obviously, it will be present posterior in the inguinal canal or posterior to the hernia, which we are talking about. So will it be at the roof? Yes. Will it be anterior to the spermatic cord? That is where there is a difference. This muscle, transverse abdominis, is not anterior. It is just roof and posterior. But look at the next muscle now. You will find the next muscle which we are talking about is internal oblique muscle, and internal oblique muscle is lying anterior to spermatic cord, or you can say anterior to inguinal canal, roof, and posterior also. Posteriorly, obviously, it will be forming the conjoint tendon. So conjoint tendon is this muscle that is internal oblique plus transversus abdominis. That means there are two muscles posterior, internal oblique and transverse abdominis, two muscles at the roof, arching fiber, the internal oblique and transversus, and two muscles are anterior. So which is the other one? Because one you have seen is internal oblique. Which other muscle will be anterior? None other than the last one, the most exterior, the external oblique muscle. So two muscles anterior, two muscles at the roof, two muscles posterior. And as we move on to the last muscle here, external oblique, this is the external oblique muscle, which you can find is only anterior to the relation. So it is anteriorly present and only anteriorly present, means it is not the roof, it is not the posterior wall, it is just anterior. But then its tendon is in turn to form floor, and that in turn tendon of external oblique, which forms the floor, we call it as the inguinal ligament. So inguinal ligament is a modification of the fibers of external oblique. External oblique muscle becomes anterior and inferior. Inferiorly, it is forming inguinal canal, and it has an opening. So what is this opening? We already have mentioned this opening is the superficial inguinal ring, because it has to open to let the testis pass, along with that spermatic cord pass. So this is what I wanted to mention. Let me take you back towards the question which we were discussing. And I think by this time, you would have got your answer already. Thank you for your patience, because this is too much of detail coming in a very short time. So what is the false statement about anatomy of inguinal hernia? Inguinal canal, you can say. So superficial inguinal ring is opening the external oblique apparatus. Yes. Is the indirect inguinal hernia medial or lateral to inferior epigastric artery? We have told if it is medial, this is Hasselbeck triangle. That will be direct inguinal hernia, not the indirect. Indirect will lie lateral. So this is wrong and this is false. That is the answer. So you mean to say C and D is okay? Yes. Why? because posterior wall is formed by transverse salis fascia. Transverse salis fascia is always posterior, like the extraoblique muscle is always anterior. They don't form roof or anything like that. And conjoint tendon, what is that? Two muscles, transverse salis abdominis and internal oblique. And what about this? Now we will call Dr. Pritesh. Indirect inguinal hernia means maybe omentum or intestine. Is it enterocele or metocele? Is it anteromedial to spermatic cord? For me, it is. But now our expert will tell you more detail. Dr. Pritesh, please kindly join us.
Thank you, sir. So let's see the question directly first and tell me the answer, then we will discuss. Okay. So see, a 54 years old male presented with right groin swelling located below inguinal ligament, medial to inferior epigastric artery. Cuff impulse was present. What is the type of hernia and its management? You first tell me the answer, then I will proceed. What are the catch points in the question? If you see the catch point, where is the location of this inguinal swelling? Medial to inferior epigastric artery. And this question is, related to the question which Dr. Rajesh Kaushal discussed. So I know most of you know the correct answer. Cuff impulse was present. What is the type of hernia and its management? Okay. Ritesh, B, Jasim, B, Madhuri, B, Murtaza, Naveen, Priyanka, Harsh, Muhammad, Staphylococcus, Pankaj, Meena, everybody is correct. Everybody is marking B. So it's because of beautiful discussion of Dr. Rajesh Kaushal. Okay. Now see, here we have to make out that whether this is direct hernia or indirect hernia. First, what do you mean by direct hernia? So hernia which is coming directly from posterior abdominal wall. So how it is coming directly from posterior abdominal wall? Via a triangle that is known as triangle of Hazelbach. What is indirect inguinal hernia? It is coming indirectly. So how it is coming indirectly? First, it comes via deep ring, traverses the inguinal canal and goes out via superficial ring. Okay. So see the diagram. If you see the simple diagram, this is the view from posterior side of abdomen. Okay. So if you focus here, you can make out that this is the triangle of Hazelbach. What are the boundaries of triangle of Hazelbach? You can see medially lateral border of rectus abdominis, medially, laterally inferior epigastric artery, and inferiorly it's the inguinal ligament. Simple. Now, in this diagram, you can see that this is the inferior epigastric artery. Can you see? This is inferior epigastric artery. So here you can see that indirect hernia is coming indirectly via deep ring, and deep ring is lateral to inferior epigastric artery. And the opening via which direct hernia is coming, that is located medial to inferior epigastric artery. That's why indirect inguinal hernia, it is also known as lateral hernia. Indirect inguinal hernia, it is also known as lateral hernia. And direct inguinal hernia, since it is located medial to inferior epigastric artery, it is also known as medial hernia. Simple. Concept is clear. So answer is direct inguinal hernia. Why? Because it was medial. Now we have to choose. See the question. We have to choose that whether we have to go for Bassini's repair or Lichtenstein repair. You tell me which one, Bassini's or Lichtenstein? This Bassini's repair is primary tissue repair. Now here we are just using sutures to repair the tissue. Which tissues? Dr. Rajesh Kaushal explained beautifully that these are the layers in abdominal wall. What can you see here? This is external oblique outside, then internal oblique, then transversus abdominis, then fascia transversalis. What we do in Bassini's repair, it is known as triple layer repair. So we take all these three layers together in the suture, and we are going to suture these three layers together to the inguinal ligament. I'm repeating again. These are four layers. This is external oblique. You can see from outside, external oblique, internal oblique, transversus abdominis, fascia transversalis. I'm taking these three layers together in the suture and then suturing it to inguinal ligament. So you are suturing three layers together to the inguinal ligament. So this is known as triple layer repair. What is the problem? If you are going to suture three layers together to some other tissue, there is increased tension over the tissue. So that's why in Bassini's repair, there is increased tension. Nobody likes tension. We don't like tension. Tissues are not going to like tension. So because of this tension, there is increased recurrence rate. So what is the problem? I'm repeating, Bassini's repair, also known as triple layer repair. It is primary tissue repair having excessive tension over the tissue associated with increased risk of recurrence. So we are not going for Bassini's. You know, Lichtenstein repair is anterior tension-free mesh repair. This is anterior tension-free mesh repair in which after herniatomy, we are going to apply the mesh, and all of you know that this Lichtenstein repair is gold standard repair for inguinal hernia. Okay, so if you see the options, there should be direct hernia. Why? Because it is medial to inferior epigastric artery, and the gold standard repair is Lichtenstein repair. So correct answer for this question is B. So I request Dr. Rajesh Kaushal to continue. Sir, please continue.
Right. Thanks a lot, Dr. Pritesh, once again. Surgery is one of the aspects which is beautifully intertwined with the anatomy. So that is really a beautiful explanation. I don't know much about these new surgical operations, but still it is always fun to know about the details. Though I'm not going to operate upon any patient, it's better that Dr. Pritesh is doing this thing. Now, I'll take one topic which is, again, interactive in terms of anatomy and surgery, quite frequently asked and not well understood. So here, as you notice, it is some injury to male urethra below the perineal membrane. It is leading to some urine extravasation. And where could be the urine extravasation? Is it the anterior abdominal wall or the deep pouch or the space of Regius? This is retropubic space of Regius. Or is it some rectovesical pouch, which is intraperitoneal? This is intraperitoneal. This is extraperitoneal. So let us find out the details. Then we can come back to this question to find the answer. And as we start, we have to look at the side view of a male pelvis. We are taking a sagittal section anterior to posterior. And as you do that, you will notice that there is a fascia, which is running on the anterior abdominal wall. In the anterior abdominal wall, you have two fascia. There is a fatty layer, Camper's fascia, and there is a membranous layer, Scarpa's fascia. We have to follow the Scarpa's fascia. So as you follow the Scarpa's fascia in the anterior abdominal wall, it will become continuous with the penile fascia, the fascia which covers the penis. Penis has one more fascia, which is Buck's fascia, but it is deeper. The one which is outer is continuation of the Scarpa's fascia called penile fascia. Now, this penile fascia becomes continuous with the scrotal fascia. So penile fascia continues with scrotal fascia, and scrotal fascia is forming continuation of. It will then continue with the Colles fascia. And what is Colles fascia? Colles fascia is the floor of superficial perineal pouch. There are two pouches we talk about in the perineum, the superficial pouch and deep perineal pouch. So Colles fascia is the floor of the superficial perineal pouch, and then it will merge with the perineal membrane. As it is merging with the perineal membrane is the floor of deep perineal pouch. That means there are two pouches, as we are telling. You can notice here, there is a superficial perineal pouch, which we just talked about, and there's a deep perineal pouch. Now, deep perineal pouch is here. You have seen the floor of superficial perineal pouch, Colles fascia. What is the roof? The roof will be perineal membrane, and perineal membrane will be then floor of the deep perineal pouch. So to have a better idea, let me draw a diagram for you, and that way it will become a bit clear. Now, as we are talking about all these discussions, we also have to look at urinary bladder giving us the urethra. So that is urinary bladder, because you're looking from side view, apex is anterior, apex of urinary bladder. Urine from urinary bladder is going to enter the urethra. And in the male, urethra has three parts. There is one part which is passing through the prostate. So we'll call prostatic urethra. And there is one which is passing through deep perineal pouch. That is called as membranous urethra. And one which is in the penile shaft is the spongy urethra. So urinary bladder sends a urine into male urethra, which has three parts: passing prostate, prostatic urethra; passing deep perineal pouch, it is membranous urethra, and then it will enter superficial perineal pouch and move towards the penile shaft. There is spongy urethra. Spongy urethra has two parts: bulbous spongy urethra, which is short, and penile spongy, which is quite long. So this is penile spongy urethra, and that is bulbous spongy urethra. This is the parts of male urethra. Now, coming back to our discussion of the fascia, we have to understand there is a bone here, pubis bone, and on the pubis bone you'll have muscles of anterior abdominal wall, like you see the external oblique muscle, say for example. So this is the external oblique muscle, which is on the anterior abdominal wall, is attaching to pubis bone. Then you will have internal oblique, transversus abdominis, and then the transversalis fascia. What is still deep to that? The peritoneum. And what is deep to peritoneum? The viscera. So this is external oblique. If you look at the peritoneum, you'll find the peritoneum is quite deeper, and this peritoneum, which lines the peritoneal cavity, is lining the fundus of the urinary bladder, and then it will go to the posterior abdominal wall. So it is coming from anterior abdominal wall deeper to the external oblique, internal oblique, transverse abdominis, transversalis fascia. Deep to that is peritoneum. This peritoneum lining anterior abdominal wall is lining fundus of urinary bladder, is now going to posterior abdominal wall. But then here we also have one viscera, and that is the rectum, which will then continue as the anal canal. So what is this pouch between rectum and urinary bladder in male? Rectovesical pouch. So this is the rectovesical pouch. When will you have urine extravasation? A rectovesical pouch. Say bomb explosion, and there is a wave of expansion. Then there'll be a wave of recession also. But that injury, that trauma, can cause rupture of the urinary bladder. And if the fundus of urinary bladder is ruptured, peritoneum is ruptured. And if peritoneum is ruptured, urine can move into the peritoneal cavity, causing ascites. So this is one scenario where bomb explosion, there is vacuum injury, rupture of fundus of urinary bladder, urine goes into the peritoneal cavity inside peritoneum. There must be a rupture of peritoneum. Then only urine can be found here, which is a dependent posture for a male. The rectovesical pouch happens rarely. What happens more commonly is pelvic fracture. When there's a pelvic fracture, rupture of the membranous urethra. And why? Because there's a pull of puboprostatic ligament. So some puboprostatic ligament is pulled and the membranous rupture of urethra. If that happens, then where the urine will go? If that happens, the urine is going into extraperitoneal, subperitoneal space. It cannot enter peritoneum because peritoneum is intact. So if it is extraperitoneal or subperitoneal, where it will be? One is retropubic space of Radius. Behind the pubis bone, you have extraperitoneal space, which is retropubic space of Radius. Urine can go there. Or it can be paravesical. Paravesical means around the urinary bladder, but extraperitoneal. It cannot enter rectovesical pouch there. No. So where else can it go? It can be in the deep perineal pouch also. This urine can be in the deep perineal pouch also. What is the floor of deep perineal pouch? Now let us move on to the detail of the fascia. You see, we have discussed one fascia, and that fascia was, let us take some other color, this color. So which fascia we were talking about? Anterior abdominal wall, Scarpa's fascia. And this Scarpa's fascia continues as the penile fascia. And penile fascia continue as the scrotal fascia. And scrotal fascia continue as. So Scarpa's fascia into penile fascia into scrotal fascia into Colles fascia. And when you say Colles fascia, this Colles fascia, which is continuous with the scrotal fascia, is actually the floor of superficial perineal pouch. So where is superficial perineal pouch? Superficial perineal pouch is here. This is superficial perineal pouch, and this is deep perineal pouch. Now, as we are following the fascia, Scarpa's fascia, penile fascia, scrotal fascia, Colles fascia, which is floor of the superficial perineal pouch, is joining the deep perineal pouch floor, and that is perineal membrane. Perineal membrane is the roof of superficial perineal pouch and the floor of deep perineal pouch. This perineal membrane is a boundary line between deep perineal pouch and superficial perineal pouch. So if injury is above the perineal membrane, where the urine extravasate? If injury is above the perineal membrane, the membranous urethra may be ruptured in a pelvic fracture. Yeah, but where is the urine extravasating? Into deep pouch and into retropubic space of Radius and paravesical periprostatic space. And can it go to this rectovesical pouch there? No, because peritoneum is intact. Okay, there is a boy riding a bicycle, bumpy road, and lands on his perineum, rupture of bulbous urethra, straddle injury. That boy is having a problem here now. Rupture of bulbous spongy urethra. And when there is a rupture of bulbous spongy urethra, urine can be at 4 places. So which 4 places urine can go? The urine can now move into superficial perineal pouch and into the scrotal layers and into penile layers and anterior abdominal wall, passing anterior to pubis bone. So passing anterior to pubis bone, it will go where? Between Scarpa's fascia anterior, external oblique muscle posterior. So external oblique muscle lies posterior, Scarpa's anterior. Between that, it can reach even to the umbilicus level. That is your answer. If there is a rupture of bulbous spongy urethra, urine can be at 4 places. 1, superficial pouch. 2, scrotum layer. 3, penile layers. 4, into anterior abdominal wall. And that was our question. Let me show one diagram now, which will correlate with the same. You see, this is pelvic fracture. And when there is a pelvic fracture, where is the urine extravasating? If it was a pelvic fracture, urine will be extravasating to retropubic space of Radius around the prostate urinary bladder, because there is a breaking of the puboprostatic ligaments. This is above the perineal membrane, above the perineal membrane. So it can be in the deep perineal pouch also, membranous rupture of urethra. But which is the question which we were talking about or frequently asked. It is a question for which you have a diagram here. This is what I just mentioned. This is the scenario we wanted to focus upon. Straddle injury, fall on the perineum, and rupture of bulbous spongy urethra. Urine in the superficial pouch, urine in the scrotal layers, urine in the penile layers, urine in the anterior abdominal wall, deeper to Scarpa's fascia, but superficial to external oblique muscle attaching to pubis bone. Scarpa's fascia continues with penile fascia, continues with the scrotal fascia, continues with the Colles fascia, and this is the perineal membrane. It is one injury below perineal membrane, the boundary line between deep pouch and superficial pouch. So I think I have taken a lot of time here, and I must now ask Dr. Pritesh to take over. Sir, please.
Thank you, sir. Thank you for explaining everything in detail. So let's see the question first, and then we will discuss. Okay. Question: a 10-year-old boy suffered perineal injury during cycling accident. Sir already explained what happens. After injury, patient didn't pass the urine. On examination, blood was present at the meatus and bladder was palpable. Which of the following statement is incorrect about this condition? So you tell me what's the answer. Which of the following is incorrect about this condition? Tell me the answer first. Perineal hematoma with involvement of shaft of penis and bilateral scrotum. B. Bulbar urethra is injured. C. Retrograde urethrogram is the first investigation done. And D. Foley's catheterization is preferred over suprapubic cystostomy. Tell me, which one is correct? Alia, D. Sushruta, D. Muhammad, D. Staphylococcus, D. Amrita, D. Everybody is correct. Santosh, D. Staphylococcus, again D. Farha, Medic, Madhuri, D. Amrita, Mrinmoy Das, Dr. Oracle, Kirtika, Simran, Fazal, Lalita, Pankaj, Gyanendra, Santosh, everybody D. Just because of beautiful discussion of Dr. Rajesh Kaushal. Okay, so have a look what happens, because this kind of question was asked in NEET PG, INI-CET, and it was asked in the latest exam also. Okay, so what is the problem? There are two types of injury. One is anterior urethral injury and second is posterior urethral injury. You know what are the parts of posterior urethra? Posterior urethra, there is prostatic and membranous. Clear? And in anterior urethra, there is bulbar and penile. Now, another question you have to tell me that what is the most commonly injured part of anterior urethra? Sir already explained. Most commonly injured part of anterior urethra. Sir already explained. Tell me the answer. It is bulbar or penile? I'm waiting for your responses. It is bulbar or penile? Alia, yes. Bulbar or penile? Which one? Okay, it's bulbar. Now, why it's bulbar? See, sometimes what is the mechanism of injury of anterior urethra? See, there is direct blow to the perineum, direct blow, kick. Sometimes there is manhole injury. You have seen on the roads, manhole injury, straddle injury, or during cycling. Generally, it's a 10 or 11 years old boy who is, habitual of cycling. And what happens? There is cycling accident. So this is the cycle bar. Cycle bar, you have seen in the cycles used by male. Cycle bar. This cycle bar, can you see here? It is going to compress or crush the bulbar urethra against the bone. Which bone? Pubis bone. So you can notice that this bulbar urethra is crushed against the pubis bone, and that's why what will happen? Injury. And whenever there will be injury, here you can see there is extravasation of urine. Not only urine, there is extravasation of blood. And this extravasation of blood, can you see it is going to involve what? It is going to involve scrotum. It is going to involve shaft of penis. So actually, what is the shape? If you see the shape, this is the penis, this is the scrotum, And this is the kind of hematoma. So can you tell me what is the shape of this hematoma, everyone? Hematoma involving shaft of penis, bilateral scrotum. What is the shape of this hematoma? Tell me. Everyone, tell me what is the shape of this hematoma involving shaft of penis, bilateral scrotum. Very good, Muhammad. It is butterfly. It is butterfly shaped hematoma. Clear? Simple. So this is bulbar urethral injury. Okay. Whenever this bulbar urethral injury occurs or urethral injury occurs, what you are going to find? You are going to find blood. Where is the blood? At tip of meatus. What else? Since urethra is injured, so obviously there will be urinary retention. And if there is urinary retention, there is another clue that you are going to palpate the abdomen and you might find palpable bladder. So what? There is urinary retention, blood at the meatus. If there is posterior urethral injury, there will be pelvic hematoma. And if there is anterior urethral injury, there is perineal hematoma. Sir explained it beautifully that there is perineal hematoma, so involving perineum, mainly the shaft of penis and bilateral scrotum. Okay. Now coming to the management, you people tell me what is the first investigation done in a case of suspected urethral injury? It is RGU or MCU? This is the question. First investigation done in a suspected case of urethral injury, any urethral injury. Doesn't matter, it is anterior or posterior. RGU or MCU? Muhammad is saying RGU. Amrita, RGU. Staphylococcus, RGU. Sushruta, RGU. Everybody is correct because we perform RGU. You inject the dye from the urethra and you see where is the injury. Sometimes if the patient is unstable in emergency, you don't have facility or you don't want to send the patient, straight away you can go for what? Urinary diversion. You tell me what is the gold standard urinary diversion performed for the patients of urethral injury. I'm repeating the question. Gold standard urinary diversion performed for the patients of urethral injury. Tell me. So we perform urinary diversion so that urethral injury is going to heal. What's the name? Gold standard urinary diversion. Very good, Muhammad. It is SPC, suprapubic cystostomy. So what we have to perform? Suprapubic cystostomy. Deepak, Amrita, Pooja, Staphylococcus, Alia, everybody is correct. It is suprapubic cystostomy. Simple. Now again, I'm going to ask you one question. Suppose this is the urethra and there is urethral injury. Are you going to insert Foley's catheterization? Yes. Generally, we should not insert Foley's catheterization. We should not go for Foley's catheterization. Why? Have a look. Imagine this is the urethra. Clear? And this is the tear. Okay. If partial tear is there, in that case, you can insert the Foley's. Why? Because over Foley's catheter, this partial tear is going to heal. Foley's catheter is going to act as a stent. But see, there should be a single gentle attempt of catheterization. If you try to insert catheter 2 to 3 times, there are chances that you are going to convert partial tear into complete tear. So I'm repeating, if there is suspected partial tear, how many attempts of catheterization? Only single attempt. What kind of attempt? Single gentle attempt of catheterization with smallest catheter should be done so that partial tear heals over catheter and catheter acts as a stent. I'm repeating, single gentle attempt of catheterization with smallest possible catheter when you are suspecting partial tear. Otherwise, no need to go for catheterization. Simple concept is clear. Now see the question again. 10 years old boy suffered perineal injury during cycling accident. Patient didn't pass urine. Blood was present at meatus. Bladder was palpable. Which of the following statement is incorrect? First, perineal hematoma with involvement of shaft of penis and bilateral scrotum. Sir explained it. It is correct. Bulbar urethra is injured. Obviously, it's the most commonly injured part of urethra. Correct. Retrograde urethrogram is first investigation done. You told me correct. Foley's catheterization is preferred over suprapubic cystostomy. It is not preferred. Gold standard method of urinary diversion is SPC. So Foley's catheterization is done only in cases where we suspect what kind of tear? Partial tear. Clear? So correct answer for this question is D. SPC is the gold standard treatment for urinary diversion. Foley's catheterization is not preferred. Clear? So I request Dr. Rajesh Kaushal to continue. Sir, please continue.
Right. Thanks a lot, Dr. Pritesh, for adding quite a substantial amount of information into my knowledge. That is a wonderful explanation. Even I gained a lot from this discussion. In fact, I can improve my lectures in the next recordings. So this was my question. Somehow I could not answer it. I'm coming back to that. Injury to the male urethra below perineal membrane, sir has already explained, it is rupture of bulbous urethra. So urine is accumulating in, we have mentioned, could be anterior abdominal wall. 4 places basically. And one of that could be the anterior abdominal wall. Now, as you say, this is the answer. Why is it not going to deep perineal pouch? Because it is below perineal membrane. If it is above the perineal membrane, then maybe it will go here, or it will be in membranous rupture of urethra. And why it is not going to space of Radius? These are both the membranous rupture of urethra. This is not a case of membranous rupture. Then what about rectovesical pouch? Why is it not going there? See, this urine collection, which is also called ascites, can happen very rarely, and it will happen only if there was a peritoneal tear. And peritoneal tear means there was something wrong with the fundus of urinary bladder. Then only it can go intraperitoneal. So it is not intraperitoneal, it is not even extraperitoneal extravasation. It is actually in that butterfly. A lot of students, they have drawn the butterfly. So not only urine, but also blood will come out, because penis is highly vascular structure, a lot of cavernous spaces are there. So the butterfly shaped hematoma, all the perineum, sir has beautifully explained. But urine can come to anterior abdominal wall also under the Scarpa's fascia. Okay, let us move on to the next topic of discussion, which is again, quite frequently asked questions. It is about the source of extradural bleed. Where is this bleed coming from? If there is an extradural hematoma. And I think I will follow Dr. Pritesh style now. Normally I get so engrossed into my teaching that I forget that what the students are answering. Now I should ask, like Dr. Pritesh, interactive session should be interactive. Okay. Oh, fantastic. I will take the names also. Muhammad is telling D, Staphylococcus, and then Dr. Amrita, so fast, can't even read. Sushruta, Alia Khan, Sanjeev. Students feel good if the faculty is taking their names. It's a good feel. I know that. I used to have that feel, of course. So it's good. Simran is there, Madhuri is there, Amrita is there, Dr. Vegas, very good. Staphylococcus is a good name. Anyhow, fantastic. You are all brilliant students, I know. See, our role is just one. We just want to guide you. And you are hardworking, you are streamlined, you are focused. Sometimes you are misdirected. So our job is just to put you on track. And to put your 3rd, 4th, 5th gear, 6th gear, 7th gear, but you should not be off track. We just put you on track. This is putting you back on track. So as you have mentioned, if it is extradural, which is also called epidural because outside durameter, and it will be middle meningeal artery. Can you tell me which branch of middle meningeal? Is it anterior division or posterior division? Anterior division, because these are all MCQs, you know. So is it anterior division or posterior division? Kindly mention. And then I'll show you a diagram. Devlina, Patra, Chandrasekhar, Hitesh, Love. Anterior, fantastic. Yes. Then what about this superior cerebral veins? What if they bleed? Where is the hematoma? Or if anterior communicating artery is bleeding, where is the hematoma? Or if there's a bleed in dural, venous, sinus? Let us find out. But at the moment, you see here, this is what we were talking about. There is a landmark which we call as pterion. And when you talk about the pterion is one H-shaped suture, which is basically frontal bone on the front, parietal bone posterior, temporal bone towards the ear inferior, and greater wing of sphenoid, 4 bones, making H-shaped suture, weak point, and one motorcyclist going without helmet, falls, trauma, fracture, bleed. Which division? You can see here now the anterior. This is the maxillary artery giving the middle meningeal artery passing the foramen spinosum, entering the cranial cavity, giving anterior division, which is prone to injury. This is the posterior division. But the problem is with anterior division, and this bleed is outside durameter, epidural, extradural. And sir will give you one question also. This motorcyclist met with accident, there's a fracture, he loses the consciousness, loss of consciousness, regains it. There's a lucid interval. For some time, he is conscious, again loses the consciousness, and this time, never to come back. So these are dangerous, very dangerous. Immediately you have to consult with the radiologist and plan if you want burr holes, evacuation of hematoma, all that. So I will not go into clinicals here. Let me just stick to the anatomy portion. See, what I want you to understand is this kind of a bleed, which we are telling. Of course, radiologically, you will have this biconvex and all those details. That is not my territory at the moment. I'm not teaching you clinical here. So this is the artery. You have to know what is the location of this artery because it is controversial. The middle meningeal artery, you told that it is anterior division under the pterion, H-shaped suture, is outside durameter. But durameter has 2 layers. It has 2 layers. There is one layer of durameter which you will find is the bony layer, which you call it as the endosteal layer of durameter. And then there is one which is towards the meninges, the other meninges, meningeal layer. So some books, they will have a difference of opinion, but you have to be careful that if this is the meningeal layer of the durameter, these layers are usually fused, and it is difficult to separate them until there is some anatomical separation. So it is outside both the layers. May it be the endosteal layer of durameter or may it be the meningeal layer of durameter, both are fused, bleeding is outside. And what if the bleeding is inside, deeper to that? If bleeding is deeper to this, then you will have subdural hematoma. And when will you have subdural hematoma? And what if the hematoma is in the subarachnoid space? So these are some of the details which we need to talk about. Let me take you to one diagram here. This diagram gives us a good idea about the orientation of the various spaces which are important for our discussion. You will notice that here, say, scalp and deep to scalp, this is the skull. So this is the skull bone and scalp is outside. Now, deep to skull, you have the durameter having double layer. And what is this double layer? There is one which covers the skull, and we call it as the endosteal layer of dura mater. But there is one meningeal layer deeper. If you look at the meningeal layer now, you will find that this meningeal layer of dura mater, they were fused together, but they separate sometime. And as the meningeal layer is going away, it is forming something like falx cerebri, dural fold, and it is then going back and fusing with the endosteal layer. So meningeal or endosteal, they are normally fused, but sometimes they will split up to enclose what is called as dural venous sinuses, like superior sagittal sinus right here, separating the two cerebral hemispheres. Now, dural venous sinus will have venous blood. The name is telling, dural venous sinus. It will have CSF also. And how the CSF enters the dural venous sinus, we'll find out. But here, which is the layer you have seen, outermost meninges? The dura mater. What is deeper to that? It'll be the arachnoid mater. So let me mark the arachnoid mater. This is arachnoid mater, and it is deeper to dura mater. I will show it on the other side also. What is deeper to arachnoid mater? Deeper to arachnoid, under the arachnoid, subarachnoid space filled with CSF. So this will be the space, basically, where you are having the CSF. This CSF can move into, let me take some other color. This CSF can move into dural venous sinus by what is called as arachnoid granulations, arachnoid villi forming granulations. So the cerebrospinal fluid under arachnoid can move into dural venous spaces, and by arachnoid granulations, arachnoid villi. And what is still deeper to this arachnoid mater? The third layer, which is pia mater. Pia means mother, very close to what? The brain. So we are now looking at the pia mater, and the pia mater is adherent almost to the brain matter. So this is the pia mater. Now you have to understand one more thing. The brain is supplied by some arteries, and those arteries, before they reach the brain, they are also in the subarachnoid space, the circle of Willis. So circle of Willis branches are in the subarachnoid space, and from there, they'll be entering into the brain matter they supply. Sometimes they can bleed. Circle of Willis, Berry aneurysm. If there is circle of Willis, Berry aneurysm, rupture, where the blood will be? In the subarachnoid space. So this leads to what is called as the subarachnoid hemorrhage. Anterior communicating artery, Berry aneurysm, rupture, in the circle of Willis, subarachnoid space, bleed, thunderclap, headache, young adult, all those things. So this is number one, subarachnoid hemorrhage. Number two, we have already discussed, but let me go backwards. So this is number one. Number two, I'll tell you that there is arteries coming here, veins will also go. And as the veins are going, let us say the brain is draining venous blood into dural venous sinus. And let us assume this is superior cerebral vein. So when the superior cerebral vein is draining into dural venous sinus, it can bleed. Old people mostly, maybe chronic alcoholic, they keep bleeding through these veins. And this blood is under the dura mater, and we call it as the subdural hemorrhage. These are also called bridging veins. Bridging veins, superior cerebral veins, they bleed, but under dura mater, So subdural hemorrhage. Old people, chronic alcoholic people keep falling here and there, and minor bleeds cannot be an emergency. But if it is continuously bleeding multiple times, one day it can become emergency. Subdural hemorrhage can present with emergency, but which is the emergency most of the time? So we have known there is one vessel which is deep to the bone, but outside durameter. And that is middle meningeal artery. And if that bleeds deep to the skull bone, but outside the durameter, both layers, then it will be epidural or extradural hemorrhage, and it is always an emergency. Lucid interval, evacuate the clot, all those things. So this is what I wanted you people to understand. I can actually quickly draw one diagram also if you wish. Say it is the skull bone here. Let us say this is the skull. Now, if that is the skull, then what is deeper to that? Will show that this is the endosteal layer of durameter, and then will also show the meningeal layer of durameter, which splits and encloses a sinus, as we are telling. So here we are telling this is endosteal layer of durameter. This is meningeal layer of durameter. Normally they are fused with each other, but sometimes they can separate. If they separate, they'll enclose superior sagittal sinus, a dural venous sinus. And this is falx cerebri, which is separating the one cerebral hemisphere from other cerebral hemisphere, if you're looking from the front view. Now, if this is durameter, what is deep to that? That we know will be the arachnoid mater. If this is the arachnoid mater on this side and that side as well, what is under the arachnoid mater? The CSF space. And if under that is CSF space, then let me take some other color, this color. What will be still deeper to arachnoid mater? The pia mater. But pia mater is very much close to the brain, and I'll show it like that only. So this is the pia mater here, and this is arachnoid mater. And what is this space? What is this filled with? It is under the arachnoid mater, so subarachnoid space filled with the CSF, and that is where we'll have the circle of Willis arteries. So in this subarachnoid space under the arachnoid mater, outside the pia mater, you can have blood vessels supplying the cerebrum, and this could be anterior communicating artery. If anterior communicating artery is bleeding, barrier aneurysm, where the blood is, it is in the subarachnoid space, and we call it as subarachnoid hemorrhage, number one. What is number two? You know, if there is an artery, there can be vein also. And if you are talking about the vein was draining here from the cerebral hemisphere into subarachnoid, into the dural venous sinus. Bridging veins, cortical veins, cerebral veins, they can bleed. And if they bleed, the blood will be actually here in this space. And if you say this space, what is this space? This space is actually under the arachnoid mater, subdural hematoma. Now, if this is subdural hematoma, what about this artery which we were having here under the skull, but outside the durameter? So under the skull, outside the durameter, middle meningeal artery and anterior division, that was we call as epi or extradural hemorrhage. So this is the first bleed we have talked about, subarachnoid hemorrhage. Number two, subdural hemorrhage. And number three, extradural hemorrhage, outside durameter. If it is inside durameter, subdural. So I hope this kind of clarifies the details so that we can answer the question, because see what is our final destination. We are not trying to become neurosurgeons here. None of us. We just want the questions to be answered perfectly and we get a PG seat. After that, it's a long life. You can have a lot of details. So what is the source of extradural hemorrhage? See, if it is from superior cerebral veins, what will you call it as? We will call it as, these are the bridging veins, we'll call it as subdural hemorrhage. And what about anterior communicating? Subarachnoid hemorrhage. And what about the dural venous sinus? Normally they don't bleed until there is a lot of damage. But anyway, dural venous sinus, is connected with the superior cerebral veins. Basically, the superior cerebral veins drain into dural venous sinus. So you can correlate the two. The only possible answer, as you already have given, middle meningeal artery, anti-division. So I have taken a lot of time. I must pass on to Dr. Pritesh now. Sir, please take care of the clinical aspects now.
Thank you, sir. So here again, first we'll see the questions and then we will discuss. So see the question. A person has been brought in the casualty with history of road accident. He had lost consciousness transiently, gained consciousness, and again become unconscious. It means what is positive? Tell me which interval is positive. Lost consciousness, transiently, gained consciousness, again became unconscious. So what is the name of this interval? This is lucid interval. NC-CET findings are given below. Can you tell me what you can see in this NC-CET finding? Hyperdense lesion. And what is the shape? Biconvex. Biconvex hyperdense lesion. Tell me the diagnosis. All of you know. What is the diagnosis? Very good. Ashok, Vegas, Oracle, Krish, D'Souza, Pooja, Payal. What is the diagnosis? Lucid interval is positive. Dr. Oracle, EDH, Staphylococcus, Muhammad, Dr. HP, Govind Singh, Rohit Gautam, Akshay Rode, Sujit Kumar Pandey, Lalita Devi, Covaxin. Covaxin is also there. Okay. Dashu, Sanjeev, Navaria, Akshay Ravi. Okay. So it is extradural hematoma, right? So obviously, what is the correct answer? Middle meningeal artery. It is frequently asked topic, EDH, SDH. So let me tell you important points quickly. It's very easy to remember. Sir has explained everything. I'm just going to add only 2 to 3 things. You can see this is the skull. Easy. And beneath the skull, imagine this is the brain, right? Between the brain and the skull, there is a pad. Between the skull and brain, there is a pad. And what is this pad? Obviously, D means dura. After that, A means arachnoid. And after that, P means pia. Simple. So what happens in extradural hematoma? You know that there is the weakest point of skull. What's that? Pterion, sir mentioned. And this pterion overlies the middle meningeal artery. So even trivial trauma to pterion, even you are going to give up one blow to somebody over this region, it leads to fracture. And what happens? It can injure the middle meningeal artery. In that case, this kind of hematoma is there. So this kind of blood collection is between skull and dura. That's why this is extradural or epidural. Between skull and dura, extradural, epidural. Now see, sometimes there is injury to cortical veins or bridging veins. And whenever there is injury to cortical veins or bridging veins, here the blood is collected. Where? Between dura and arachnoid. You can see that this EDH is red colored and this SDH is blue colored. Why? Because you know that in EDH, the injury is arterial, bleeding is arterial. And in SDH, there is injury to cortical or bridging veins, bleeding is venous. So SDH is like that. If you see the shape, EDH biconvex, SDH concavo-convex. Simple. Now see the diagram again. Here, if you focus on this diagram, first look at this. This is middle meningeal artery. Why it is injured? Because of a fracture of pterion. And whenever there is injury, the blood is being collected between skull and dura. Now just focus here. These are bridging veins. And in SDH, these cortical veins or bridging veins are injured. And that's why here you can see the blood is collected between dura and arachnoid. So this is subdural. Got it? So extradural, subdural. Lots of times this question is asked in there is a clinical scenario and then they give this NC-CET finding. So first see here, hyperdense lesion in both. Here you can see what? Biconvex hyperdense lesion, also known as lenticular shaped hyperdense lesion. And here you can see what? concavo-convex? Okay. One question I want to ask you, you tell me in this EDH and SDH, which one is having, see the image, NCCT finding, which one is having the midline shift? Tell me everyone, you can easily make out. Which one is having midline shift? Midline shift. Tell me, SDH is having midline shift or EDH is having midline shift? Look at the image. Alia Khan, EDH, Govind Singh, SDH, Bharat Morla, SDH, SDH. What is midline shift? Can you see? This is the midline. So if the right-sided structures are going towards left or one side is going towards left, can you see this is the midline? And can you see the ventricles? Yes. So which one is having midline shift? SDH? Yes. So now everybody is correct. It is SDH which is having midline shift. You got it? So this is the difference. In EDH, arterial bleeding. In SDH, venous bleeding. EDH, even trivial trauma can cause. In EDH, there is lucid interval, which is positive. And for both, in head injury, investigation of choice for diagnosis is NCCT. How we drain the hematoma. So for drainage, we go for either burr hole, we create burr hole and drain the hematoma if it's small. And if large hematoma is there, we open the skull, perform craniotomy and then drain it. You got it? So if we get the question or see the question again, this patient is having history of road traffic accident. Lucid interval is positive. NCCT finding showing hyperdense lesion, which is biconvex. Most likely injured vessel is middle meningeal artery. Why? Because here the diagnosis is EDH. Clear? So correct answer for this question is D. Okay. So now I ask all the students, if you want to ask any doubt, you can ask directly in the chat box. We are going to reply. And let me tell you, integrated learning is always fun. It helps to retain facts for long duration of time. It removes fear of integrated questions and it improves your performance. Muhammad was asking one question. Let me clarify. He was asking the question related to hernia. See, this is the inguinal canal anatomy. Look at this. Let me show you. So just look at this. This is inguinal canal anatomy. Okay. So what is this? This is the deep ring. This part is inguinal canal. And this is what? Testis. This is superficial ring. So if you see this deep ring, generally the cord structures are coming out over from the medial aspect, of deep ring. So relatively this lateral aspect is empty. When hernia is coming, can you see the hernia is coming like this? Clear? So in indirect hernia, the content is coming like this. So if content is coming like this, you tell me the relation of sac with cord. Can you see? This is the cord. This is the sac coming. So what is the relation? And in sir question D option was in indirect inguinal hernia, it is anterolateral to the cord. Can you see? So this is the cord and the sac was coming like this. It was coming like this. So obviously it is anterolateral. And we discussed that in direct hernia, the hernia is coming directly from the posterior abdominal wall. Directly. So what is the relation of sac? Can you see? This is the cord and this is the sac. So sac is posterior. So I'm repeating. In indirect inguinal hernia, sac is anterolateral. It is anterolateral. And in cases of direct inguinal hernia, the sac is posterior. Got it? Now, if you want to ask any question, let me see the chat box. Okay. So I think it is clear now. So sir, please carry home message or some kind of advice to the students.
Yeah. So we just wanted to give you one information here, which we are supposed to, that you can download the PrepLadder app, which is all the 19 experts in service of you. And you can watch these information just to transform yourself from the basic level to beginner level to the advanced level. The link will be there in the YouTube. You can find that, how to go about it. And at the moment, like we have some time, you can ask us, the queries can be entertained if you have any. Let me just look at the chat box. Yes, thanks a lot. Thank you very much for having all the patience and giving us time to be of some help to you. Yes, that is correct. That is correct. One student has really expressed my...
We can read the emotions, sir. No need to read the question. So many fans over there of Dr. Rajesh Kaushal. It's great to see.
Sir, they are equally, like, they love you at very much, like I have seen, because sometimes we may not speak upon face, but I should, because if there is a good thing to talk about, we should always tell on the face. And students really love your sessions, so crisp, so brief, and so lucid. Sometimes I go into too much of detail, and a lot of diagram drawing is there, but your diagrams are very simple.
That is required for understanding, because you are going to create the priming, and then delivery is going to happen.
Fantastic.
So I think we should end, sir, because it is already very late, and students
right.
are already saying thank you, sir. Thank you, sir.
Right. So it was a great pleasure, Dr. Pritesh.
Same here, sir. Same here. It was a great session. Thank you very much, everyone. Love you all. Thank you for joining us here.
Right. Take care. Bye-bye.